Okay, everyone, thank you so much for coming today to our session, The Modulator Effects on Different Organ Systems. Today we have 4 great speakers. We'll be reviewing the endocrine system, the gastrointestinal system, the immune system, and the CNS. So right now, let's start with
So
Daniel.
This symposium will run like all the others. So the speaker will get 20 minutes to talk, then we'll do 5 minutes of questions. And then if there's time at the end, we will have probably an amazing roundtable discussion up here with all the speakers kind of answering, I guess, philosophical questions. And so to start it all off, I get to introduce our first speaker, who I think is the definition of rising star. His name is Kevin Scully. He's a pediatric endocrinologist over at Hasbro Children's Hospital. And come on up, Kevin. You're welcome.
Okay.
All right. Thanks so much, everybody. So my name's Kevin Scully. I am a pediatric endocrinologist in Rhode Island, but I dabble on both the adult and pediatric side of things when it comes to CFRD management in particular. And today I have the pleasure of talking to you about what we know about the effects of CFTR modulator therapy on the impact of dysglycemia and beta cell function. So these are my disclosures. So as we know, as people with cystic fibrosis are living longer, healthier lives, we're seeing an emergence of the non-pulmonary complications of cystic fibrosis. And I'm biased, but I would say none more so than CFRD. We typically quote rates of about 2 to 5% of children, 10 to 20% of adolescents, and 30 to 50% of adults will develop CFRD at some point in their lives. So that latter may actually be an underestimate, particularly in the setting of those individuals with more severe genotypes. And as we see from some of the data depicted here from the registry here in the US, there may be some message that the incidence is decreasing slightly, but the overall prevalence continues to rise. And despite these amazing care advancements that we've had in the world of cystic fibrosis for the last several years in particular, CFRD unfortunately doesn't appear to be going anywhere. This is probably a review for everybody in this room, but why do we care? Why do we care about dysglycemia in people with cystic fibrosis? Well, in addition to the known complications that we have in other forms of diabetes, which are definitely increasing in CFRD, microvascular disease, macrovascular disease, name something that we care about in the world of cystic fibrosis clinically, and CFRD, and especially poorly controlled CFRD, makes that worse. Exacerbation frequency, lung function, bone mineral density, worsening of hepatobiliary disease, and potentially most importantly on this list, the psychosocial and economic implications for these patients. This is an incredibly medically overburdened patient population at baseline, and you take a horrible condition like diabetes with multiple daily injections of insulin, frequent blood sugar monitoring, and a reminder every time that you put food in your mouth that you have a chronic illness. And that can really significantly impair quality of life for these individuals. Part of our issue in determining best screening practices and management practices in people with CFRD is that we really have an evolving lack of understanding of the pathophysiology itself. So historically, we felt that CFRD was due to the so-called bystander theory, where you'd have thick viscous secretions within the exocrine pancreas that causes obstruction, this inflammatory cascade, and ultimate zygomatic autodigestion of those adjacent tissues, so in this case, the beta cells. But we know that people with cystic fibrosis-related diabetes typically maintain at least 50% of their beta cell mass. So this can't be the picture in and of itself. There's been a lot of research into the role of insulin resistance, and certainly in the acute setting it plays a role. Stressors, glucocorticoids, exacerbations, what have you. But studies that have looked at the difference in individuals with and without CFRD or with and without pancreatic sufficiency haven't seen major differences in terms of insulin sensitivity. So again, there has to be more at play. Many of us, myself included, were super hopeful that it was going to be CFTR expression within the beta cell themselves that was going to be the primary culprit. And there was some initial data that was promising, but in recent years, both in animal and human models, we haven't consistently seen expression of CFTR protein within the islets. And that's depicted in this figure here with insulin in green, glucagon in purple, and as you can see isolated here, an absent of red, which is CFTR protein. So there's probably a crosstalk or paracrine effect at play that we haven't quite figured out, and that's a big area of research for sure. We know the end result is the same. This is a state of insulin insufficiency, regardless of the cause, and that's categorized by early insulin secretory deficits, and clinically, the way we see that, these postprandial or post-meal spikes that worsen with severity and duration with time. In thinking about these potential pathophysiology components, it also helps us think about the mechanisms by which therapies like modulators might help alleviate some of the dysglycemia in people with cystic fibrosis. So if therapy works at the level of that exocrine pancreas and improves ductal function, might that improve the microenvironment of the islet and improve dysglycemia? If you have improvements in overall health, pulmonary function, nutritional status, might that alleviate some of that chronic inflammation and have a knock-on effect? What about the role directly of impacting insulin resistance? Could improvements in CFTR function, expression, protein misfolding play a role? And lastly, and potentially the biggest, what about, again, paracrine or indirect mechanisms? So a lot to be figured out here. So I want to focus the rest of the talk on kind of the meat and potatoes, I guess, is what do we know about the effect of modulators on dysglycemia thus far? So we're going to walk through the last several generations of modulators. We're not going to talk really about Alyftrek because there's not any data but we'll talk about the last several generations. So back in 2012, when ivacaftor was first approved, a couple of different groups have first attempted to look at this question of how does this impact glycemia. The figure on the left here is from Balin's group at the University of Minnesota. This was an open-label pilot study of 5 individuals with cystic fibrosis, both youth and adults, and varying glycemic status. And what they did was they compared data from baseline to 1 month post-therapy. And what they looked at was the oral glucose tolerance test, everybody's favorite test, and an IV version of that test. And what they found was in the majority of individuals, all except one, significant improvements in the insulin response, both on the oral and on the IV side of things. And also interestingly, 2 individuals at baseline that didn't have an acute insulin response. After therapy, they did. So this was positive in suggesting that there might be a direct role of ivacaftor on insulin secretion and beta cell function. Dr. Kelly, one of our Envision co-mentors, conducted a similar study, 12 individuals, youth and adults. They compared 4 months of OGTT, mixed meal tolerance test data, so think OGTT with some fat and protein thrown in there, and glucose potentiated arginine studies, which are kind of dynamic, fancy ways of looking at beta cell function. And they found a significant improvement in that key early phase insulin secretory deficit. So again, the ivacaftor data was overall really promising. Of course, the issue was that it was really only applicable to a small percentage of our patient population. Like many things, we were hopeful with lumacaftor, ivacaftor that we would see better results, and like many things, we didn't really, unfortunately. So there was a mix of studies at that time. The figure on the left is from a French prospective observational study. This was the one study that really potentially may have showed some benefit. They looked at 40 individuals, 12 months prior to and after starting lumacaftor, ivacaftor, and they actually did find some significant differences in that 2-hour blood sugar, which is our key marker that we diagnose CFRD based off of, and some improvements in glycemic categorization. So going from CFRD to kind of more of a pre-diabetes state or abnormal glucose tolerance down to the normal glucose tolerance range. Unfortunately, the rest of the literature looking at this didn't find the same results. One of my mentors, Amir Mahit, did this study on the right. This was a similar study, about 40 individuals, homozygous Delta F508, and they looked at OGTT data at baseline 3, 6, and 12 months after lumacaftor, ivacaftor, and they unfortunately didn't find any significant improvements in fasting blood sugar, 2-hour blood sugar, or area under the curve assessment of insulin or glucose. So unfortunately, the data in lumacaftor, ivacaftor was not as promising as that first generation. But then hope again reemerged with ETI in late 2019. And we were really hopeful that we were going to see some of the same trends in pulmonary function improvement. I'll ignore that screen. And nutritional status that we did see in, that we'll see those trends in glycemia as well. This is a table I threw together. Please don't read it in any detail. But it's just to kind of say there have been a lot of mostly small mix of prospective and retrospective studies that have attempted to look at this over the last several years. A lot of them are small and varying durations. I kind of subjectively color coordinated this just to say studies in green generally showed some beneficial glycemic improvements. Studies in red, not so much, and orange somewhere in between. If you're really bored on the plane ride home, these references will be at the end of the talk. But otherwise, we're going to hone in on a couple of these studies for the last little bit of the talk. So myself and my mentor, Dr. Putman, were lucky enough to study ETI pretty soon after its approval in 2019. We did a prospective observational study that was significantly impacted by COVID, like many studies from this time. But we primarily looked at continuous glucose monitor outcomes, so CGMs, in individuals, adults, with CF and at least one copy of the Delta F508 mutation. And over a 3 to 11 month period, we did find significant improvements in some of these key measures. Average glucose, standard deviation, percent time in range, so 70 to 180 milligrams per deciliter, and percent time in some of these hyperglycemic ranges. And those findings were a little bit more impressive in the folks with CFRD as well. The problem with our study, these early studies, was that they were relatively small and soon after the approval. And what we didn't know, and we haven't known for the last several years, is are these kind of early potential glycemic benefits going to stand the test of time? What about larger, longer prospective studies looking at these questions? So the subsection of the PROMISE study, PROMISE Endo, is the most robust and best study that has looked at this to date. That's a lot of our Envision mentors are a part of, led by Christine Chan. This was a prospective observational study across 10 centers, about 80 individuals, aged 12 years and up with at least one copy of the Delta F508 mutation. And what they did was they looked at A1C primarily and 3-hour oral glucose tolerance testing. They also looked at C-peptide and insulin levels, so that gave them the ability to do some kind of dynamic beta cell function analysis over baseline, a 12 to 18 month period, and that should say 24 to 30 month period. Overall, the findings, what they found was a significant improvement in glycemic status, but these improvements were relatively modest. So the figure on the left here, this looks at hemoglobin A1C. So the individuals in blue were not on insulin. The individuals in orange were. You can see the 3 study time points there. The dashed lines for the y-axis, hemoglobin A1C, that's your quote-unquote normal A1C of less than 5.7, the pre-diabetes range 5.7 to 6.4, and 6.5 and above being diabetes. And what they found was a mean A1C that did decrease over that study period from 5.8 to 5.5%. The graphs on the right are twofold. The top is glucose, the bottom insulin secretory rate. The baseline data is in orange, and the 24 to 30 month data is in blue there. What they found in those intermediate points, the 12 to 18 month, were some glycemic improvements, but unfortunately these weren't sustained at the 24 to 30 month, and the only thing that held true was fasting blood sugar. There were some changes in the slope of this insulin secretory rate, suggesting maybe some benefits in that first phase insulin secretion, still not a lot of significance. And insulin sensitivity actually decreased a little bit throughout the study duration. But I guess kind of importantly, and depending on if you think about it kind of glass half full or glass half empty, what they found was there wasn't significant decline in beta cell function. So while there was an improvement, there also wasn't decline. This is a Sankey plot that they did looking at the glucose tolerance based on their OGTT. So individuals in pink here had normal glucose tolerance. Individuals in yellow, indeterminate, those are the folks that go up to 200 at the 1 hour mark but come back down to the normal range. In green, impaired glucose tolerance, kind of more of that classic pre-diabetes state. And in blue, CFRD. And what you see here is some general movement between categories, but not statistical significance. I think about 12 or 14 moved in either direction and kind of nulled each other out at the end of it. So the conclusions, important in that we found some glycemic benefit, but again, overall relatively modest findings. Just recently was this phase 3B trial. So this was a 48-week open label trial at 38 centers nationally and internationally. They similarly looked at individuals 12 and above with at least one copy of the Delta F508 mutation, that primary outcome being the 2-hour oral glucose tolerance test value, but also looked at some key secondary measures, safety, glycemic category, what have you. And this is a lot of their results crammed into one slide, but we'll kind of go through it slowly. The overall conclusion was a little bit more promising or declaring more significance than what the PROMISE study probably suggested. And they particularly highlighted that from baseline to this 48-week point, the individuals that improved from a normal glycemic category, 13% at baseline, increased to about 36%. Individuals with a normal A1C less than 5.6 also increased from about 36 to 54% with an absolute reduction of about 0.16. And unlike PROMISE, 2-hour blood sugar did decrease significantly. This is graphically shown on the right here. So this is the least squared mean hemoglobin A1C change. This is the change in glycemic category over that time. The one point I do want to highlight, and it's not a criticism of this study per se, but of maybe OGTT as a whole, is that in the screening phase, in that lead up prior to ETI initiation, 13% of their participants went from an abnormal glucose tolerant state to a normal glucose tolerant state without any intervention. So a limitation of OGTT and really any study, but important in looking at some of these results. When we look at some of the secondary outcomes and supplemental information, the deductions are probably tempered a little bit. So in the folks that had CGM data at baseline for 7 days and during that follow-up period, they didn't see any significant improvements in some of these key measures. They didn't see any significant improvements in the 21 individuals that were on insulin that had appropriate data during that period in terms of reduction of their daily dose. And in their measures of beta cell function, insulin C-peptide, insulin secretion, and insulin resistance, again, no significant changes. So another really important study, a large study that says some modest improvements, but probably a little bit more modest and in line with PROMISE than on first read. Doing all right. This is the kind of great confounder. There are a lot of confounders in any study in the post-ETI era, and there's been a lot of focus on this particular topic at conference this week and in general. But it's just to say that the changing cardiometabolic landscape significantly impacts our study of this. We know from our registry data and registry data abroad, the Italian cohort depicted here, rates of overweight and obesity are increasing dramatically for our people with cystic fibrosis. What we don't know is what's the optimal BMI for health, and is there any benefit to pushing that BMI? And we probably all kind of know, probably not. And the data over 30 certainly isn't promising, and a lot of us are rethinking the utility of using BMI versus better measures at all. But how this landscape is going to impact dysglycemia, beta cell function and burnout, CFRD prevalence and pathophysiology is a huge area of interest, and a talk in and of itself. I'll skip this for time's sake. So just kind of in conclusion, the data from the modulators is a little bit variable. Ivacaftor was promising but limited. Lumacaftor, ivacaftor, not so much. NETI, we are seeing probably some modest improvements in A1C, fasting blood sugar, maybe glycemic category, maybe 2-hour level. What we're generally not seeing, and albeit every patient and person is different in their journey, right? But in general, what we're not seeing is significant change in glycemic categorization and significant reduction, if not discontinuation of insulin altogether, which unfortunately means we still have a lot of work to do. There's a lot of confounding variables like OGTT, our understanding of the pathophysiology. I think probably the most important question is going to be what happens with this young cohort. What happens with the individuals that start CFTR modulator at a very young age as they progress? How is that going to impact their beta cell function? Are their beta cells going to be more preserved? Are we going to see CFTR, or are we going to see CFRD prevalence decrease 5, 10, 15, 20 years from now? And unfortunately, time will only tell with that question. So these are my references. Again, if you're bored, scan that QR code and you'll get the whole list for your plane ride home. Just to highlight a couple of the key references, PROMISE in the middle here, that phase 3B study. And this is a fantastic systematic review that was done in Italy just earlier this year. And then lastly, I'll just say thanks to the foundation for supporting me, to my great mentor team, particularly Melissa Putman down in the front row here, about the best mentor anybody could ask for, life and academics, I guess. And then obviously my wonderful family as well. So thank you.
Great. Thank you so much. Thanks for that amazing presentation. We'll just keep Kevin up here and we'll take 5 minutes of questions. Recognizing at the end of the session, we'll also have time to speak with all of the speakers.
Does this work? We also have a couple. Oh, yeah. Go first, please.
Hi, Raul from Nationwide Children's. Besides these glucose manifestations, is there any other diabetic, like kidney, renal failure, wound healing, or cataracts?
Yeah, I think historically we're so focused on the pulmonary outcomes, of course, but everything has changed in the post-modulator world. So all of these complications and considerations that we think about in poorly controlled type 1 and poorly controlled type 2 diabetes really are definitely starting to manifest. So we're just starting to see those numbers and that data tick up because this patient population is starting to age. But I think the general consensus is that trend's definitely going to continue.
Thank you. Twice, this is Dr. Chicago. Twice I've seen the 2R OGTT value lower than the baseline on some of these kids. Do you know, can you comment on that?
Yes, yeah. Could go on for ages about that. The short version is that think of the problem with CFRD is not just insulin insufficiency, but dysfunction. It's beta cell dysfunction, it's alpha cell dysfunction, it's both glucagon and insulin. It's firing during the fasting stage for no good reason. It's that kind of missed initial insulin secretory response in the body going, oh no, I'm late, and then overshooting on the backside and causing that reactive hypoglycemia. So we see a lot of that indeterminate hyperglycemia, that peak up into the 200s at 1 hour, and a lot of us are doing that 1 hour level because we know that correlates with risk of developing CFRD down the line. So I think it's dysfunction at the level of the islets as a whole, for sure.
Does anybody else in the audience have a question? Because we have two from our virtual audience. Okay, so our first question from our virtual audience is, curious why OGTTs and A1Cs are used in studying CFRD instead of continuous glucose monitoring when we know how much OGTTs miss CFRD diagnoses, especially with the CFRD progression is early and phase 1 insulin response is impaired and phase 2 insulin response is still robust, therefore making it only more likely that a 2 or 3 hour postprandial.
Yeah, if I could push the like button on that would I definitely would. A lot of us use CGM, and I'd say anytime in my own practice when somebody fails an OGTT, the first thing I do is I put a CGM on them, because not everybody wakes up first thing in the morning unless you go to Dunkin' and get a 6 and 6 like half of New England and has 75 grams of pure sugar on an empty stomach. So you might fail that test, but your day-to-day dysglycemia doesn't reflect a need for insulin necessarily. So a lot of the times we're stuck twiddling our thumbs trying to figure out, okay, when do we do this? When do we add this horrible component to their care? What's the amount of dysglycemia? The biggest issue is that we don't have a consensus on what CGM parameters are meet the diagnostic criteria, right, for CFRD. And designing that study, there are people working on it, Christine Chan probably most of all, but doing that study well would require a head-to-head long-term study, CGM versus OGTT, correlating to outcomes. So by the time that data's done well, the technology is probably going to be obsolete. So we're in a bit of a pickle, and I'd agree with all of that, basically.
There's one more question here, then I have a question for you, Kevin.
Thanks.
Is the incidence of CFRD dropping in patients on CFTR modulators?
I've seen a little bit of a mix. I think some data says maybe the ivacaftor data, but again, those individuals, it's a little bit different, right, in terms of pancreatic sufficiency, the disease severity, what have you. So a little bit hard to tell, maybe dropping, but prevalence with people living longer, at some point screening practices getting better, and certainly as we're using CGMs and things like that, I think the number is only going to go up and up for a while.
And this is my question. Have people noticed changes in enteroendocrine hormone levels on ETIs like GIP and GLP-1?
Yeah. So I'd be lying if I said I knew that data well. I think my overall understanding thus far is no, that it has been looked at. But if there are any endocrinologists in the audience that want to correct me, please. But I do think it has, particularly in recent years, obviously, it's been studied, yeah.
And I have one last question. Has anyone looked at the data separating out pancreatic insufficient and pancreatic sufficient patients to see if the glucose tolerance is different?
CFRD is less common in people that are pancreatic sufficient, and whether that is kind of chicken or the egg, right? Whether it's just because their overall disease state might be a little less severe, or if that is from that component at the level of exocrine dysfunction or exocrine, inflammation kind of destroying. It's a little bit probably hard to tease out. I think historically we were even saying OGTTs every 3 years for those individuals, but I think with the changing world, I personally anyways, I still get them every year. All right.
Well, thank you so much.
Great.
And then our next speaker is Nicole Green. Nicole's Associate Professor at the University of Washington, Seattle Children's Hospital.
Good afternoon, and thank you for inviting me to speak today on the gastrointestinal impact of CFTR modulators. My disclosures are that I have 2 Cystic Fibrosis Foundation grants that support my research, but not relevant for this presentation. So I think we've heard ad nauseum, if you've gone to any GI talks this conference, that GI disease is a central feature of CF, so affecting the hepatobiliary system with liver disease, biliary cirrhosis, portal venopathy, and then the luminal side, so starting at birth with meconium ileus, and then dysbiosis, inflammation, and then, of course, the pancreas with exocrine pancreatic insufficiency, pancreatitis, and then just increased rates of GI malignancies. Full disclosure, I am not going to speak on the pancreas today, so apologies if you're wanting to hear about that, but we've got a lot of other things to cover. So this is from the CF Foundation's 2024 Strategic Plan Input Survey that identified digestive system complications as being a top issue for both research priorities and symptom burden, and then a follow-up survey of over 500 adults with CF and their caregivers. About 40% of the respondents indicated a moderate or severe burden with bloating or gas, diarrhea, constipation, and abdominal pain. Not to be too US-centric, this is from the UK and the James Lind Alliance, and as you can see here, the 2023 priorities, number 3 here was how can we relieve GI symptoms such as stomach pain, bloating, and nausea. So issues have not gone away with the emergence of modulators. What tools do we have to assess GI response to these CFTR modulators? So none of the tools are perfect, but you'll see these used repeatedly in various studies. So for GI symptoms, typically patient-reported outcome measures or surveys. Intestinal pH has been measured with the wireless motility capsule, intestinal inflammation with stool calprotectin, as well as M2 pyruvate kinase. And then liver disease, labs, which we all know are not perfect measures, as well as liver fibrosis scores, and then measures of liver stiffness using elastography. And then intestinal transit or constipation can be assessed with the Bristol stool scale, as well as the motility capsule. So the questions here is that we have the CFTR modulators, and do they have any impact on what we think to be the main drivers of GI disease and CF. So that would be intestinal inflammation and increased permeability, altered intestinal pH, as well as intestinal dysbiosis. And if we do have an impact on these drivers, are we in turn seeing an impact on GI symptoms, gastrointestinal cancers, and liver disease? So starting with intestinal pH, as we know, there is reduced buffering capacity in people with CF. This is required to neutralize gastric acid in the proximal small bowel. So this has implications for nutrient absorption, and the optimal pH to dissolve the enteric coating of enzymes, for example, is between 5.5 and 6. So this graph here is just showing controls in blue and then individuals with CF in orange. And the points between A and B for each color are that time period where we're at the optimal pH. So as you can see, definitely deficient and delayed in individuals with CF. What did ivacaftor do? We did see a significant improvement in the early ability to neutralize gastric acid with ivacaftor. So the green here is pre-ivacaftor, the red is post-ivacaftor, and then there's the horizontal hash line at that pH of 5.5, that optimal pH. And you can see here that there was, early improved ability to neutralize that gastric acid, and the x-axis is showing minutes from gastric emptying. This is unpublished data from the PROMISE study. So this was looking at the effect of elexacaftor, tezacaftor, ivacaftor on intestinal pH. And here, this graph, the red circles are CF individuals pre-ETI, the white as post-ETI, and the black is healthy controls. And as you may appreciate here, there's no substantial impact on intestinal pH with ETI. Then they performed a subgroup analysis. So first point is that they did not appreciate any significant differences or trends at any locations of the GI tract in those with F508del homozygous variants, and that was 10 individuals. And then they looked at 6 individuals with no prior history of modulator use. And actually, they ended up showing a reduction in mid-small bowel pH. So not what we would expect, so a lower pH. Moving on to intestinal inflammation. So it's been well described that individuals with CF have chronic intestinal inflammation and reduced epithelial integrity compared to healthy controls. And this has been shown in whole gut lavage, demonstrating increased concentrations of inflammatory markers, capsule endoscopy showing small bowel mucosal pathology, so edema, ulcerations, and then these elevated fecal inflammatory markers, calprotectin, and M2 pyruvic kinase, which I'll touch on more. The pathogenesis of this intestinal inflammation is multifactorial. Of course, CFTR dysfunction itself results in mucus hyperviscosity, hyperacidity, and then CFTR is also expressed in the enteric nervous system, so you get intestinal dysmotility. There's evidence of increased intestinal permeability. All of this may play into the dysbiosis that we see in CF, as well as sort of iatrogenic factors with antibiotics and PPIs, then a high-fat diet, and of course, exocrine pancreatic insufficiency. So looking at some results, so in terms of intestinal inflammation, so the PROMISE study looked at calprotectin as a measure of intestinal inflammation, and this is in individuals 12 and above, and found that there was an improvement in calprotectin at both 1 and 6 months with ETI. So the abnormals went from 50% of individuals having an abnormal calprotectin to 16% at 6 months, but they did not find an association between change in fecal calprotectin and change in symptoms. So again, maybe addressing a driver of GI disease, but not having an impact in this case on symptoms. PROMISE Peds was again an ETI, the pediatric sub-study in 6 to 11-year-olds, again showed a decrease in those with abnormal calprotectin from 64% at baseline to 35% at 6 months, and an increase in the normal from 22% to 40%. Recover is similar to Promise, but out of the UK and Ireland. It's a post-approval study examining the impact of ETI on various outcome measures, including GI symptoms and markers of intestinal inflammation. And this initial study was 12 and above. And similar to Promise, they demonstrated a decrease in fecal calprotectin from baseline to 1 month, and that difference was maintained at 6 months. They also looked at M2 pyruvate kinase and found that as a marker of inflammation, and found that concentration decreased significantly by 76% from baseline to 1 month, and then sort of was sustained at 6 months. M2 PK is interesting because it's actually a marker of cell proliferation or epithelial turnover, and it's elevated in inflammation and various cancers outside of the CF realm. So potentially, could this be suggestive of downregulation of carcinogenic effects of CFTR deficiency? Moving on to the microbiome and dysbiosis. So we've heard a lot about the dysbiosis in individuals with CF, so decreased species diversity, delayed maturation, altered functionality, and altered composition of the GI microbiome, in the sense that there's a reduction in protective and anti-inflammatory bacteria, fewer short-chain fatty acid producing bacteria, and short-chain fatty acids are beneficial in a lot of ways, from an inflammatory perspective to immune regulation. There's also an increase in bacteria associated with inflammation and colorectal cancer. And then there's also been studies correlating certain pathogenic bacteria with things like fecal calprotectin. SIBO is more difficult to diagnose. It's small intestinal bacterial overgrowth, so more difficult to diagnose and study, but it's generally thought to refer to a presence of excessive numbers of bacteria in the small bowel causing GI symptoms. And the prevalence has been reported up to 40% in individuals with CF. Symptoms associated with SIBO include bloating, flatulence, abdominal discomfort, and diarrhea. So these really common symptoms that we saw highlighted at the beginning in the surveys. In severe cases, you can see steatorrhea and malabsorption of essential nutrients in SIBO. So in terms of how do CFTR modulators affect intestinal dysbiosis, there are very limited studies and there are definitely mixed results. This IVACAFTA study looked at 16 people with CF, 8 children, and overall beta and alpha diversity did not change with IVACAFTA. However, there were decreased relative abundances of Enterobacteriaceae, which is generally thought to be pathogenic, and an increase in the genus Akkermansia, which is thought to be favorable with IVACAFTA, and that's around 6-month data. Interestingly as well, there was the decreased relative abundances of Enterobacteriaceae was associated with reduced levels of stool calprotectin. What about ETI? So this is from the Promise study, recently published paper. So actually with ETI, they saw a lower Shannon diversity index and species richness at 6 months compared to the baseline or pre-ETI in 1 month. So that's actually thought to be less favorable. But when they looked at individual bacteria driving differences and the bacteria that significantly changed, they found these 7 bacteria that had significantly decreased relative abundances following ETI. And I've just circled here the 5 species with decreased relative abundance correlating with calprotectin normalization after 6 months of ETI. So of the individuals who had an abnormal calprotectin at baseline and that normalized, these species correlated also with a decrease. And then I've just starred here the species associated with intestinal inflammatory disease outside of CF, as well as liver disease. So potentially some positive findings with ETI. This was just showing that we have differing results. So this is another study by Riesener et al. Looking at ETI in children, 39 children aged 6 to 18. And they collected stool at baseline or pre-ETI 6 and 12 months, and actually showed an increased diversity and richness with ETI, so a more favorable outcome, and a decrease in antibiotic resistance gene abundance following ETI. And that might be just reflective of decreased antibiotic use with ETI. So now moving on to what people are feeling or care about the most within the patient population, so symptoms. We assess these symptoms, as I said at the beginning, from these, at least in these larger studies with patient-reported outcome measures. So I'm mainly going to cover here the PROMISE and RECOVER results. So PROMISE, as I said, was a study of ETI in those 12 and above, and they use these patient-reported outcome measures, so PAGI-SIM, PAC-SIM, PAC-QFL, the Bristol Stool Scale, and a stool frequency questionnaire. And this was assessing both upper GI disease, constipation, constipation-related quality of life, and then sort of stool caliber and frequency. These are the results, and this is the 12 and above study, and that red vertical hashed line is with the baseline scores set to 0. So anything to the left of that line suggests is reflective of a lower score, so reduced symptoms severity. So as you can see, just looking down quickly, there's general improvement in symptom severity scores, but actually when looking at the scores themselves, we think they're unlikely to be clinically significant. However, in the sub-analysis where they looked at those starting off with more severe symptoms, they did see more improvements after ETI initiation. PROMISE Peds, so now the 6 to 11-year-olds with ETI. Overall at baseline, this group had lower GI disease burden compared to the adult cohort. And as you can see here with similar display of results of these scoring systems, there wasn't any significant changes in total scores for any of the patient-reported outcome measures. But if you looked at some of the subdomains, postprandial fullness, early satiety, and bloating, the changes looked significant or are statistically significant, but turned out to be not clinically meaningful. RECOVER, so that again is this multi-center study out of the UK and Ireland, looking at ETI in those 12 and above, used a different outcome or patient-reported outcome measure. They used the CF-AB score, which is a CF-specific abdominal symptom questionnaire. And they actually showed more positive results with ETI. So just to orient you to the spider plot, the red here is before ETI, the green is the 2-month scores, and then the purple is the 12-month scores. So in the total score, as well as all the domains, including pain, reflux, bowel movements, disorders of appetite, and quality of life, there was significant improvement in all areas, especially at the 2 months, as well as the 12 months, but that effect was slightly muted at the 12-month. And then this is some results for the pediatric. So this is out of Germany for CF centers in Germany using this pediatric version of the CF-AB score. And this is looking at results at baseline, pre-ETI, and then on ETI. And as you can see here, there was a significant decrease in mean total score, as well as the domains of pain, quality of life, impairment, disorders of bowel movements or lower GI, and disorders of appetite. So different results for the same drug, and we need to think about that more, and there's been lots of discussions. This is a survey. It was an international survey, but most of the respondents were out of the UK. And this was completed with 88 people with CF, 22 parents or family members, and 54 healthcare professionals. 80% were on a modulator, with 87% of those being on ETI. And this is a busy slide, but essentially, they show that there seemed to be no improvement or worsening even of GI symptoms with modulator. So if we just, for example, take the top right figure, so the symptoms are down along the y-axis. The white bar is better or improved symptoms. And then as you move to the right, the light gray and the dark gray are either no change or worsening of symptoms. So as you can see here, the majority of respondents reported either no change or worsening of their symptoms on modulator, of their GI symptoms. Quick note on constipation. So PROMISE did not report significant changes in reported constipation. The pediatrics sub-study did show a reduction in reports of a constipated stool pattern at 12 months. What about DIOS, or distal intestinal obstruction syndrome? So this is a single center study looking at DIOS-related hospital admissions and ED visits. And the conclusion here is that CFTR modulator use over 3 years was not associated with a decrease in either of these DIOS-related events. Moving on to the liver. So again, just to remind ourselves of what assessment tools we have for the liver. So liver labs, so AST, ALT, GGT, and these are far from good tools to assess liver disease because elevations are common and they'll fluctuate based on many things, including illness, antibiotics even. But that's what we have. And we also, what might be more helpful actually is GGT, which is a liver lab. And GGT levels greater than 21 are thought to be a marker for the presence or risk for advanced liver disease. Then we have these hepatic fibrosis indices, which are more helpful than the labs alone. And these are using lab values, but to generate a fibrosis score. So APRI is AST to platelet ratio, GPR is GGT to platelet ratio. And what you'll see in studies also is that cutoffs for like liver fibrosis differ and are not well defined for individuals with CF or for pediatrics and adults. But we are using those, as well as elastography, which is a measure of liver stiffness. So this is results from the BEGIN study. So this is looking at ETI in children aged 2 to 5. And what I'm showing here in the graphs are percentage of children who had the various labs as being abnormal, which we defined as greater than 1.5 times the upper limit of normal. So what we can see is that at 6 months of ETI, the proportion of children with CF with abnormal AST and ALT decreased, but there was no change in the proportion of children who had abnormal GGT or direct bilirubin. But at least we can say that there were no early signs that ETI was hepatotoxic in children after 6 months. Looking at those liver fibrosis scores, no change with ETI at 6 months, and the same with elastography. So here the red was abnormal at baseline and then at 6 months. And so no change in the liver stiffness after 12 months. PROMISE and RECOVER, those adult 12 and above, merged their outcomes for looking at liver disease. And they, at 2 years, showed a significant reduction in number of participants with GGT greater than 22, which is associated with increased risk of advanced liver disease. There was no significant change in percentage of participants with APRI or GPR above threshold, and no change in liver stiffness over 3 years. So, in conclusion, we can say there does seem to be improvement in intestinal inflammation and dysbiosis, but as so far, the modulators have demonstrated limited effect on GI symptoms or disease. Establishing consistent outcome measures and assessment tools and thresholds across studies will be valuable. And while reversing GI and liver disease might not be possible with CFTR modulators, maybe we can prevent the development of disease by targeting the underlying mechanism if modulators are started early. And then, of course, some outcomes like GI cancers and advanced liver disease will just need longer follow-up, larger data sets and collaborations to determine the impact of modulators. And that is all I have.
Thank you so much. Do we have any questions from the audience? So I have one question for you. What do you think that the role is in diet for intestinal inflammation in CF? And can you comment on how that might change pre and post modulator therapy?
Yeah, I'm biased. I'm very much into diet. So I do think, at least if we extrapolate from other GI diseases, that diet is important. And it's just because I've tried to do the studies, and I think Kevin's tried to do diet studies. They're really hard to do. And it's really hard to control for diet. But I do think that we are seeing and some people with modulators are gaining a lot of weight and self-changing their diet, but I think the studies need to be done. But I do think it affects inflammation for sure, at least if we extrapolate from inflammatory bowel disease and that kind of thing.
Thank you.
Happen from Central Connecticut and Hartford, Connecticut. Is the take-home then on ETI and liver in that it doesn't go ahead and mean that there's less, it doesn't protect or decrease the amount of liver disease that we see. On the other hand, from a complication standpoint, we're not seeing more complications of inflammation or stiffness and the major side effects that we're constantly watching for when we're giving ETI.
Yeah, I don't think I think hepatotoxicity, we see that with the liver labs, but I think long-term, worsening liver damage from modulators, we aren't seeing yet. Time will tell. I think it's going to be hard to reverse those people with advanced liver disease, but yeah, hopefully our hope now is prevention if we can do anything with modulators.
Thank you for your talk. The intestinal microbiome is obviously enormously complex, and so richness and diversity are sort of one set of metrics you could look at. Has there been any research looking at things like the metabolome or the proteome, things like short-chain fatty acids, and the relationship between those and level of inflammation?
Yes. So I've done some work looking at metabolome with advanced liver disease with ETI and changes there compared to individuals in PROMISE who did not have any liver disease. And then Jennifer Duong is also looking at, I think, planning to do metabolome work. So she published that microbiome data, but she's planning to look at metabolome work as well with ETI.
We have a couple questions from the virtual audience, but I think we'll keep those till the end, if that's okay. Thank you so much. Great, and our next talk will be from Dr. Benjamin Kopp.
Thank you. All right, thanks to the organizers for including the immune system as an organ in this session. I'm really excited for that. Although I've been having flashbacks to my first case report as a fellow about 15 years ago when all the screens went blank and I had nothing to look at. So hopefully that doesn't continue here. All right, so these are my disclosures. These are the objectives for this talk. So we're going to switch gears a little bit. So hopefully everybody's ready to talk a little bit about some basic and translational science and really think about the cellular effects of CFTR modulators. So we're going to focus on macrophages as kind of our main orchestrators of innate immune responses, and we have a lot of data to talk about and how CFTR is important and how modulators change that. We're going to go into some emerging science and some other factors about innate immune cells and how CFTR may play a role. And then I'll finish with some thoughts about what we need to think about going forward. And I'm going to apologize ahead of time for many studies on the immune system that I'm not going to be able to get to from colleagues in the audience today. I want to start with the fact that 70% of the kids that I see as a pediatric pulmonologist have persistent bacteria despite highly effective CFTR modulators. So I think it's a really important premise for why we need to think about the immune system, even in this era of highly effective modulators. And it really dovetails into the chronic problems that we've seen in CF. We know there are very unusual and persistent sinorespiratory infections that occur in all ages. As mentioned in the last talk, systemic dysbiosis, certainly in the gut, but also in the lungs and the sinuses. And overall, there's chronic inflammation that persists throughout the lifespan. And really, this points to the fact that CF is a relative immunodeficiency. we don't have therapies that are targeting this. We don't treat this like other immunodeficiencies. And I think that's something that we really need to address moving forward and think about it in our therapeutic strategies. So what's the key to bacterial eradication? Well, in my lab, we're really kind of trying to think about this in a tripartite fashion. And it's not just the immune system, although we love the immune system, but really it's how our immune cells interact with pathogens, the metabolites they produce, the virulence factors they produce, but also importantly, things from our lived and built environment. So there are chemicals, there are stressors that can influence these communications. And it's really this melding of these pathways that's really important. So I'll try to touch on a little bit of each of these as we think about innate immunity. So the first part of the study I'm going to go through is our longitudinal CF immune study. So this is a cohort of pediatric and adult individuals with CF where we get a lot of fresh biologic specimens from people pre and post CFTR modulator initiation, and we match them to non-CF healthy controls, and we link this to clinical metadata. And so we really hoped by learning, as we look at people before and after starting modulators, what happens to their immune system. And like I said, I'm going to focus on macrophages because I really think these are kind of the orchestra leaders of the innate immune symphony that's going on in the body. And macrophages are really unique cells. They respond, again, not only to other pathogens, other immune cells, nutrients in our body, but they're really critical in a variety of processes, and they can do both pro and anti-inflammatory responses, but also repair. So when they're not working well, it really affects a lot of the factors in our body. So the first question we wanted to ask is, what are modulators like ETI doing to impact innate immunity, in this case, macrophage CFTR? And so looking at CFTR expression, we can do this in a variety of ways. I'm just going to try to show a lot of pictures today to help bring this to the forefront. So this is confocal microscopy, looking at CFTR expression in green. We have a plasma membrane marker, WGA, in white, and then RAB7 is an endosomal marker, and then DAPI is a cell nucleus. And so I've highlighted with the purple arrows that you can see that CFTR, both in non-CF and then patients, people with CF on ETI, it really localizes to the plasma membrane. It has a nice response post-ETI. But you can also see it co-localizing with other structures like these RAB7 endosomal markers. And we looked at a variety of other markers, LAMP1 for lysosomes, EA1, another early endosome marker. And one of the other important facts from this study is not only was this localized to the plasma membrane, but as I'm showing in the purple arrows, because those are little busy figures there, when we add an inflammatory stimulus, we actually see an activation of CFTR. So the important point here is that CFTR in our immune cells is really a dynamic process. So it's not going to be fixed just to the plasma membrane, but we see it throughout the cell, and we see it kind of dynamically responding to infection and inflammatory stimuli. So a little different than other organ systems in the body. And what about functional standpoint? So there's a little bit of controversy, whether CFTR, the role of it in immune cells, but to look at a functional aspect of how ETI might impact this in our immune cells, we have a halide efflux assay. So to walk you through this, there's a chloride-sensitive probe. So when we have a functional CFTR channel shown here in orange, as this allows chloride, and in this case iodide, connected to efflux out the cell, we get a fluorescent signal. But in CF, when this channel is either not present or it's closed, that signal is quenched. So we can read this as a fluorescent output over time. And this works kind of like Usine chamber assays in the epithelium. So we get kind of a max stimulus. We stimulate our channel with forskolin and IBMX. And then we can inhibit the channel with CFTR inhibitor to get the direct dependence on CFTR and to get an overall readout. And so for individuals, we can get a max response over time. And one of the first important points that we saw was when we took matched blood monocytes and derived them in culture to macrophages, if we don't supplement with this ETI over the course of the differentiation process, within 24 hours, they lose the effect of ETI on their CFTR function. So it's a very short-lived effect in our immune cells. And the other important point in this last column down here in blue is we really saw very heterogeneous responses in terms of CFTR functional changes in our individuals pre and post. So you can see some of these individuals had very robust changes in CFTR function, but many were flatlined or just marginal changes. So it's going to be one of the big takeaways that I talk about today is that the overall immune responses are very heterogeneous. And so what about how does this impact clinical outcomes? Well, in our cohort, we had some typical clinical findings. So sweat chloride was robustly reduced in all the individuals, many of them below our threshold of 60 for a diagnosis of CF. We saw kind of a typical immediate response in FEV1 over 3 months, which kind of plateaued and then maybe even had a little bit of decrease over a year in this cohort. But importantly, there was no correlation if we looked at their post-ETI sweat chloride and their change in FEV1. So our traditional biomarker of sweat chloride as a CFTR response does not really indicate who's going to have a good clinical response. But conversely, if we look at our macrophage CFTR functional changes, we see a really nice tight correlation down here in the bottom shown by the purple arrow, and changes in macrophage CFTR function on the x-axis correlated with their sweat chloride. So this is a nice robust biomarker. And then the other two panels show the macrophage CFTR function again on the x-axis with FEV1 in the middle and then BMI on the right. And it's a little bit of a busy aspect there, but I'm just highlighting that for each individual, they had one copy of F508, and then their other gene variants are shown on there. So our individuals that were homozygous for F508 had the best responses overall. But there's correlations very tightly with their clinical responses and their immune response from a CFTR standpoint. So what about the functional aspects of our immune system? What we care about, how we clear dead debris, how we clear bacteria. So we looked at erythrocytosis, this is the process whereby our macrophages clear dead cells from the airways, particularly dead neutrophils that are highly inflammatory. So I'm showing you uptake of green fluorescent labeled neutrophils in the middle and the quantitation of this. So again, with the purple arrow, you can see that there were very heterogeneous responses in individuals pre and post ETI. And on the left is the quantitation, which again has gone away, but and this was something that we could actually recapitulate in non-CF by adding a functional CFTR inhibitor channel to block the CFTR channel. So this is a direct dependence on CFTR. And we validated this with some EM images because I always think pictures tell a lot. And so again, you can see these dark circles are the uptake of neutrophils in non-CF and in post-ETI. So this is overall a pretty robust response in terms of clearing the dead neutrophils, but not quite fully the same level as non-CF. So what about phagocytosis? So here we're showing red fluorescent labeled bacteria. This was a strain of Burkholderia, but we've also looked at Staph and Pseudomonas. And the interesting thing here was we actually saw an impact of ETI in both non-CF and CF on phagocytosis. And so this may tie into the fact that some pathogens like Burkholderia actually have virulence factors that affect healthy macrophages and other immune cells. So again, tying in what we need to be thinking about with the pathogen-specific virulence factors as well. But again, you can see this is really tight in non-CF and very heterogeneous in CF macrophages. And the other important aspect of this is when we add an airway stimulus, so in this case, airway supernatants derived from people with CF sputum, we actually lose this benefit of ETI as shown by the purple arrow. So this may be one of the driving factors of why we see persistent infection is we can get a benefit from modulators, but there are continued factors in our lung airway and our lung milieu that impact important aspects of our immune function. And so why is this happening? This is one of my favorite pictures. This is scanning EM that we've pseudocolored our macrophages purple and their interactions with bacteria, which are labeled red. So I think you can clearly see here, this is the actin cytoskeleton around the macrophage. And in non-CF, we get the really activated pattern. They're actively uptaking the bacteria. And typically in CF, without a modulator, we're seeing the bacteria in close approximation without an activation of the cytoskeleton. Post-ETI, we do see an activation of the cytoskeleton, but it's disorganized, it's disarranged. There's a lot of ruffling of the cytoskeleton. And so this, the molecular signals that are leading to phagocytosis are altered post-ETI. And I'm not going to get into too much of the science behind this, but basically there is some signaling factors that relate to road GTPases that control our actin cytoskeleton that are altered. So their expression at an RNA level is heightened post-ETI, but the functional activity remains far below non-CF. And there's some really interesting work from the Bruscia lab this morning that is pointing to a key signaling molecule called esrin that may be the critical factor in this pathway. And then importantly, from a proteomics study that Hazel postdoc in the lab just completed, although we saw the upregulation of many pathways post-ETI in the blood, many aspects relating to cell signaling, cell adhesion, how our immune cells adhere and move are actually downregulated post-ETI. So again, we're not solving all the problems here. So the key points that I want you to take away from this section on the macrophages is that we're overall seeing very heterogeneous responses. It's only a partial recovery in our immune function, and it's really leading to these persistent phagocytic defects that we need to tackle better. But we have promise from being able to understand our immune system as a biomarker of CFTR functional responses. So as we think about CFTR, the other interesting aspect is when we use modulators, they don't not only impact CFTR and chloride signaling, but they also impact other ion channels in our body. And so from recent work where we were looking at the role of the ENaC sodium channel in innate immunity from John in the lab, we actually found that ETI therapy was able to robustly reduce overexpression of ENaC in macrophages, as shown through 2 different subunits of ENaC. But importantly, the reverse was not the same. So if you used an ENaC inhibition, it does not improve CFTR. So this is a direct off-channel effect of modulating CFTR that we have to be aware of. And if you're interested in more of the aspects of how ENaC and other ion channels besides CFTR impact innate immunity, I'll direct you to that paper. And then the last part on the macrophages that I'll just point out is one of the aspects of our environment that I mentioned at the beginning. So it's important not to ignore the other factors that we encounter. And so in this study, we were looking at the impact of e-cigarettes on innate immunity. And in the top panel, I'm showing you that our macrophages are typically reprogrammed to a glycolytic or pro-inflammatory phenotype, as shown in the red, during e-cigarette exposure. And this is not rescued by ETI. And the really important part of this study is when we looked at functional impacts of CFTR, as shown in the bottom panel, e-cigarettes themselves can actually downregulate CFTR function, and they are negating the benefits of ETI and restoring CFTR function. So this is a very amenable thing that we can go after from a policy standpoint and thinking about modifiable factors as opposed to other aspects of CF care. And for other aspects, if you're really interested in the environmental impacts and immunity, I'll point you to this paper. And then we're excited about an ongoing study where we're partnering with some of our public health colleagues at Emory and Ohio State to really think about a variety of factors in the environment and how they're impacting our immune system and its aging and some potential therapies that might be able to mitigate it. So what about other immune cells? Well, neutrophils are certainly really important in CF. There's going to be some exciting work coming from Nationwide Children's and the Partida Sanchez lab led by Frank, who's a postdoc there, looking at neutrophils and their effect from ETI. And so similar to what we see in macrophages, CFTR is highly expressed in neutrophils. So on the top, you're seeing PCR comparing neutrophils to epithelial cells. They have immunofluorescence, again, showing a nice kind of localization of CFTR in green on the plasma membrane, as well as protein effect from Western blotting. And then with ETI, they see a really nice, robust response in CFTR co-localization to the plasma membrane, here where they have a plasma membrane marker in red. So exciting to see some similar effects in neutrophils, but maybe even more robust than in macrophages. And they also have some exciting aspects on the functional aspects of neutrophils in this study. So one of the key things that neutrophils do is produce an oxidative burst. So they produce toxic oxygen chemicals that help kill pathogens. And typically in CF, as you can see in red, this oxidative burst is reduced. And we see this also in macrophages. And ETI is particularly impacting one of the signaling components of this NOx complex, which is phosphorylation of a p47 FOX. So they see a nice improvement in there. So this functional output is going to improve on therapy. What about other aspects of neutrophil function? So this is not from our lab or colleagues. This is from Rob Tarrin's group. And they were looking at neutrophil responses to ETI, and using a proteomics approach, they saw a variety of pathways that were up and down regulated. But one of the critical parts of this that they saw related to store-operated calcium entry. So really calcium flux that helps drive many of the degranulation processes of neutrophils. And here in the middle, you can see that this flux of calcium is really highly upregulated in CF neutrophils at baseline. And they're able to challenge this a little bit with ETI. But importantly, in this study, they actually used a small molecule peptide, ELD607, and were able to really reduce this overexpression of calcium influx in the cells and make these neutrophils less hyperactive. So this is actually a promising strategy that may be an adjunct to ETI or for those that are not eligible for CFTR modulators. And in a similar fashion, a group from Europe was looking at another potential impact of ETI and neutrophils. So this case, they're looking at extracellular ATP. And this is a factor that can drive inflammasome activation and one of the critical pro-inflammatory pathways in our immune cells. And so on the left, they're actually showing a really tight correlation between extracellular ATP presence in sputum from people with CF and FEV1. So as these levels are higher, your lung function's worse. This is driven predominantly through neutrophils based on their cellular analysis. So again, higher production, the more neutrophils that are present. This is actually able to be nicely resolved post-ETI. So CD39 is one of the critical regulators of this extracellular ATP production, and they see a nice, robust response. But they can also impact this with a protease inhibitor, alpha-1 antitrypsin. So again, showing you a potential impact of therapies that synergize with ETI or potentially for folks that are not able to take modulators. So it's really promising to see some of these studies coming to front that may be able to impact our immune system going forward. So I think the takeaways from this are there are a lot of reciprocal changes in non-CFTR ion channels that we need to be aware of. We need to think about the environmental toxicants and how they're impacting our people with CF. And there are some really nice, responses to ETI and neutrophils and potential new targets to think about. So what are we missing? Well, I'm just going to end with a couple quick slides on studies from my lab that are here that I'm not going to talk about. But Irina presented today on the role of mast cells, kind of a forgotten cell in CF that are tissue resident. These are really quite abnormal in CF that we're finding. And ETI is actually only partially restoring CFTR in these cells and is actually leading to a hyperinflammatory, hyperactivated state that may play a role in many of the Th2 and asthma responses, as well as allergic responses in our individuals. And Irina won Best in Show today, Best Science Abstract. So it was if you see a person walking around with a giant check, that's her. So really congrats to her. Hazel is another great postdoc in the lab who's working on immunohormonal dysfunction, and we think this might be a key pathway that ties into some of the endocrine and GI symptoms that were talked about earlier. So macrophages are actually sequestering catecholamines like epinephrine, and this can also be a nutrient source for pathogens, and it's really unclear how modulators are impacting this process, so I encourage you to talk to her as well. And then the last study I think really ties in with Nicole's work as well is from Sam Durfee, another postdoc in the lab who's looking at a systematic approach where we're testing both systemic responses from the blood, airway, and stool responses at the same time to really get a more comprehensive assessment of what's going on with our immune responses and inflammation. So where do we go from here? I think there's a couple things that we can think about, but we really need to be adding more complexity to our models and really considering all these factors, thinking about the immune response as a really therapeutic change that needs to happen in CF, and thinking about how we can better capture these responses in time. So I'll thank my lab and colleagues for all their contributions.
Hi, do we have any questions from the audience? Thank you. That was an amazing presentation.
I hope I didn't
here we go.
bore everybody with the basic science. So.
Thank you. With the classic macrophage defects, you get into infections like salmonella and others. We don't see those, and one question I have is, how much is this is primary, how much is secondary? Is it really affecting the gamma interferon IL-12 axis? And then maybe later you can comment on the new non-CF bronchiectasis medication and maybe its potential use in CF. Because that is actually one contraindication for that medication is live viral vaccines, Brinsuprius, what I'm talking about.
Yeah, those are some good questions. So I think from the first part, there's a combination, right? There's definitely intrinsic factors to CFTR that drive immune dysfunction. We've shown that in these studies. We've shown that with CRISPR-Cas knockout, and other groups have worked on this as well. So there's a direct dependence on that. It's not a complete it's not like chronic granulomatous disease where you have a complete knockout of your oxidative burst, but there's a definite contribution. But as I showed, there's a real effect of the milieu in our lung. There are, extracellular vesicles. There are other proteins and lipids and things, and translocated factors from our gut that are impacting. So there are many factors that we have to consider from that side. And I think in terms of the second question, in terms of the new FDA approval, it's going to be interesting to see how that impacts things, especially maybe in people that are moving towards a non-CF bronchiectasis kind of picture on modulators. But it may also be important to think about the timing of when we do these things. So someone that's early on in life is going to have a different immune setup and kind of epigenetic change in their airways and their system versus someone later in life with a lot of established bronchiectasis. So those things need to be very personalized.
We have another question from the floor.
Hi. So you referred to the effects of e-cigarettes on CFTR. So could you elaborate? What's the mechanism of action?
Yeah, so there's a direct effect on CFTR itself, which is partially nicotine dependent. We did not look at some of the other factors that have been shown with cigarettes, like acrolein and things. So those would be important things to think about. The composition of e-cigarettes is very heterogeneous, which is kind of limits a little bit of that, but there's a direct impact on that. And then it's, again, programming this kind of metabolic switch where they get hyperinflammatory as well.
Okay.
But yeah, the nicotine aspect of it.
So for cigarettes, you see effects on mRNA expression, CFTR protein expression, and channel function. So what are the effects for e-cigarettes?
Yeah. So we do see an effect on protein expression and function. That's why I was showing you the functional output in the data there. But so it's kind of similar to the cigarette story as well.
Okay. Thank you very much.
Yep. And it's actually it's specific to macrophages. It's less impactful on epithelial cells. So we did look at both.
So which epithelial cells?
Human bronchial epithelial cells.
Okay, thanks.
Yep.
I have a quick question for you. I'll get two questions, I guess, and I think they're relatively simple. Maybe not, but do you see does CFTR function play a role in B cells and T cells? And also, do you see any changes in, and you mentioned this briefly, I think, any changes in differentiation in terms of what cell types are present in a patient with CF, and does that change with ETI?
Yeah. So those are good questions. So there's definitely a role for CFTR in adaptive immunity. There's been some talks here from Elaine Saavedra on the T cell dysfunction that's going on and how that's impacted. There's a lot less on B cells, but there's a little bit out there as well. I think it's an understudied area that needs better looked at. In terms of repopulations, so we published a little bit on that, so you can kind of see shifts in their circulating populations, and then other groups across the US and Europe have shown some of the airway sputum and bronchoscopy BL kind of findings that shift over. You see, less neutrophils that come in, some of the shifting in your T cell populations. And interestingly, there are like myeloid-derived suppressor cells and Tregs that are upregulated in CF that downregulate post-modulation as well.
Okay.
So.
Do you have any other questions? Well, thank you so much for that great talk.
Thank you.
And to round out this phenomenal symposium, I want to introduce Anna Georgiopoulos from MGH in Harvard, who's going to talk to us today about the CNS.
Thanks so much for including me in this wonderful symposium. I think there's many areas of intersection of mental health and CNS with some of these other talks today, so it's very exciting to listen to them and think about that. These are my disclosures. So what I'd like to cover in the time we have is what we know about CFTR and the CNS, and that'll be quick because we don't know much. And then to think a bit about CFTR modulators and neuropsychiatric symptoms. So what are we observing? How do we understand that and how do we manage it? And then tell you a little bit about new research. Okay, so a long time ago in a galaxy far, far away, there were no modulators. And, we used to think that CF had nothing to do with the brain at all. If there was any depression or anxiety, that had to do with the stress of living with a chronic disease, which is true and makes a lot of sense. But then CFTR was discovered in neural cells in the brain. And you see here CFTR in the healthy human temporal lobe, and also a study that is looking at CFTR protein expression in the fetal central nervous system, both fetuses with and without CF, and seeing differences in expression there. So we don't know the impact on brain development, and we don't know what the relationship of this is to elevated rates of depression, anxiety, ADHD, and neurocognitive problems, sleep disturbances in people with CF, again, all elevated versus the general population. So there's been very limited study of, one study really, of structural differences in the CNS of people with CF compared to controls. This was a study, a structural brain MRI in 5 male adults with CF compared to 15 healthy controls. They found significantly increased gray matter density in people with CF that indicates tissue injury in a variety of areas of the brain, and also significantly reduced T2 relaxation values, which indicates acute tissue changes, again, in a variety of different areas. And importantly, these are areas that control mood, they control anxiety, cognition, respiratory and autonomic functions. And the authors speculated that there are a lot of reasons we could be seeing this. One could be a neuronal and axonal swelling, which could have to do with the hypoxia and hypercapnia that's prevalent in people with CF, although these folks had mild to moderate lung disease. It could be increased neuronal size or number, so abnormal development, in other words. It could be increased vascular density, which could be due to increased metabolic demand, or reactive gliosis, which could have to do even with chronic pain. And then recently, a study came out looking at vascular function in the CNS in people with CF compared to controls. So they actually found no structural differences. They also looked at structure here. But when they were looking at vascular differences, they found there were some differences. There were no difference in global oxygen extraction fraction, but they did find a higher cerebral metabolic rate of oxygen consumption in people with CF. And they did find higher gray matter cerebral blood flow, but again, only in some regions. And speculation about could this be due to endothelial cell dysfunction or vascular inflammation. And I don't have time to talk about some of the neuropsychological findings. There have been a couple of studies, but I will just highlight that there are some differences in people with CF compared to controls in things like working memory, processing speed, which are worse in people with CF-related diabetes and mitigated to some extent with ETI therapy. Okay, so what about CFTR modulators and neuropsychiatric symptoms? So what are we seeing here? This is a review paper that was highlighted yesterday in the opening plenary. You can access it for free at the QR code there. But we looked, the Prioritizing Research and Mental Health Working Group looked at key gaps and study design consideration in a variety of areas: preclinical work, pharmacokinetics and pharmacodynamics, mood, anxiety, quality of life and self-perception, neurocognition, sleep, and symptom management, and found that there really are limited studies that identified some behavioral changes with modulator exposure in rodent models of depression, anxiety, and cognition. And longitudinal human studies that report mean changes generally show no change or improvement from pre to post modulator. particularly these studies emerged in Europe, where they had a little more lead time than we did, and didn't, we missed some opportunities here. However, there are case reports and there are single center pre-post studies that identify subgroups that report new or worsening symptoms. So where are the gaps? We have limited data, particularly in pediatric studies, some reliance on case reports and single center samples, and some methodologic challenges. So we have reason to think, right, that if you start a modulator, and for some reasons that we'll talk about in a moment, but also, again, just thinking psychologically, if your health is improving, you would expect that your mood may improve, your anxiety may improve. So we expect improvement. But if we're pooling group means and we're expecting some improvement, at least some people, then we're really going to miss the folks who may be getting worse, right? So again, we're really thinking about what is this small at-risk subgroup and how can we attend to them? And, it's not so ethical these days to do a randomized trial where we would withhold modulator therapy from folks who may benefit from it, right? So what we need is to define the role of CFTR in the CNS. We need preclinical studies, mechanistic studies, large observational cohorts, and having primary mental health outcomes with age-appropriate measures. Okay, so how do we understand what could be happening? So I won't really spend much time on the hypothesis, first of all, which in many cases, there may be no relationship, right? Common things are common. People with CF often have depression and anxiety. They could have, these are things that wax and wane. They could have a worsening of depression and anxiety at the time they start a modulator that has nothing to do with it at all. And there can also be psychological impacts, right, of the change in your life, survivor guilt, new anxieties about, I didn't plan for retirement, and all kinds of things going on. But today I want to really focus in on these hypotheses 3 and 4 about briefly drug-drug interactions and then more direct impact of modulators. Okay, so what about drug-drug interactions? So there are, quite a variety of pathways, right, that could be at play here. These are just a few examples. So we do know that lumacaftor can decrease levels of some of the recommended antidepressants, citalopram, escitalopram, sertraline through the CYP3A pathway, which could lead to relapse of depression and anxiety. So when kids were taking Orkambi, right, we had to think about, do we need to increase their dose of one of these SSRIs when they start Orkambi, or at least monitor for worsening. On the other hand, ivacaftor can increase the levels of some medications and possibly escitalopram. So there's not a study directly looking at that, but through the P-glycoprotein pathway, that's certainly a possibility, and we could expect to see potentially increased side effects of escitalopram. And so do we need to reduce the dose, maybe not proactively, but watching for any sign of intolerance there. And I wanted to mention this last piece because lots of folks will use over-the-counter supplements and things to treat their mental health. And St. John's wort in particular is a CYP3A inducer. It can decrease Trikafta levels, and that could make the Trikafta less effective. So that's really important to share with people, and always ask them, of course, what else they're taking besides what we prescribe. So we know there are individual variations in modulator metabolism, right? The studies, such as they are, kind of all over the map, and where concentrations are. And these differences in drug and metabolite concentrations could contribute to differences in patient response. There's really very limited data at this time correlating concentrations to modulator adverse event. There is one case series of 10 people with CF who had side effects, mainly neuropsychiatric and liver toxicity on ETI. Interestingly, a fairly older population, which makes some sense, and they all improved with dose reduction. We saw that they saw that their concentrations at full dose were higher than you would expect in the registration studies. And Emma Tillman and others are doing some work to develop PK/PD models that might be able to predict response and side effect risk, not only for neuropsychiatric side effects, but also for liver problems and other kinds of side effects. All right, what about off-target direct effects of CFTR modulators? So, a modulator could have a drug-specific effect, but it has nothing to do with CFTR modulation, right? So, Elena Schneider did a really interesting study showing that ivacaftor, first of all, it crosses the blood-brain barrier, but it also binds to neurotransmitter receptors, all kinds of receptors, so serotonin, norepinephrine, delta opioid receptors, dopamine transporters, and she did a test comparing with fluoxetine, right, an antidepressant, in rat models of depression and anxiety, and found actually ivacaftor was a great antidepressant, just as good as fluoxetine. And had a small human study to go along with that, showing improved anxiety in a combination modulator. And, could there be direct effects as well? Well, again, CFTR is present in neural cells in the brain, so there could be an effect that could be related to mechanism of action. So one hypothesis that Mike Van Alzaker and a group of us laid out had to do with thinking about the RACC, which is important in emotion regulation neurocircuitry, and we know that decreased GABA concentration there is associated with neuropsychiatric symptoms, anxiety, depression, OCD, psychosis, kind of you name it, it has to do with GABA. And CFTR and the GABA-A are both chloride channels, so could there be some impact of CFTR modulation on GABA function via chloride? And we hope to be able to do some elucidation of this. And Daniel DeVore's group looked at a rodent model, looking at action potentials in primary rat hippocampal and cortical neurons, and for both ETI and VTD, found interference with those action potentials. So could suppression of neural activity in the hippocampus, which again is the memory region of the brain, could that be related to neurocognitive challenges? Well, we have not translated that to human setting, but it's certainly an interesting hypothesis. And Leah Resnikoff has done some interesting work in this area as well, looking at neurobehavioral effects of elexacaftor and ivacaftor in wild-type mice. And she didn't look at tezacaftor because it has low blood-brain barrier penetrance, right? But so if you look at mouse models, this shows here, if you see here, this open field test or elevated plus maze. These are rodent models of anxiety that are well established in neurobehavioral medicine. And elexacaftor elicited anxiety-like behavior in these wild-type mice. And so they hypothesized this could be through enhancement of CFTR trafficking and function, so kind of CFTR overexpression that creates kind of too much chloride, right? And then ivacaftor actually induced depressive-like behavior. And so, again, is there an imbalance between excitatory and inhibitory neurotransmission at play? So these could be CFTR independent effects, we don't know, but they were able to confirm that there was CFTR mRNA in the amygdala and hippocampus, and we need to replicate these studies in CF animal models, chronic dosing studies. This was acute administration, right? So what happens over time, and looking more mechanistically. And if any of you saw Leah's talk yesterday on inflammation, it was really a fascinating study. Again, looking at mice, but administering IL-1 beta to the lungs and then seeing neurobehavioral changes in those mice. But really fascinating, these were sex-specific, so worsening in the female mice, but not in the male mice. So does this tell us something about, again, why there may be sex differences in mental health conditions in humans? Okay, and we've been hearing about the gut and the microbiome and inflammation. So I don't need to introduce this much after we've just heard a wonderful talk about it. But we know that serotonin regulates mood, cognition, appetite, and it's highly present in the gut. Another marker to think about is zonulin, which is a protein that regulates gut permeability. And we see elevated levels of zonulin in inflammatory conditions, dysbiosis, OCD, bipolar disorder, ADHD, depression. There's been some really fruitful research around zonulin in long COVID. So this may be an area worth considering. And I also wanted to highlight a new study that has nothing to do with CF, but is really interesting in terms of this intersection of mental health and the gut. So in this study, this was again a rat study looking at the SSRI escitalopram, and again these kind of standard neurobehavioral tests. This one was the forced swim test in rats, which is a depressive-like behavior, and they found that not surprisingly, SSRIs, escitalopram, improve these depressive-like behaviors, but also that it restored intestinal permeability and brain tissue integrity, and then also resulted in significant changes in the microbiome and increases in sphingolipid metabolites and hippocampal proteins that correlated as well. So the hypothesis here is that escitalopram one of its mechanisms of action may actually be by modulating sphingolipid metabolism through the influence of the gut microbiome. So food for thought. Okay, so how do we manage it? Well, we had a whole pre-conference course at the ECFS meeting in Milan about how we manage neuropsychiatric symptoms associated with modulator use, but I'll breeze through this and point you to some resources. So our mental health guidelines, our joint international guidelines from the CF Foundation and ECFS have not yet been updated in the modulator era. But the European standards of care have been updated recently, and mental health is included with physical health. So when we're initiating CFTR modulator therapy or any variant-specific therapy, people with CF and families should be encouraged to promptly report any significant physical or mental health changes to the CF team. It's just part of the picture, right? And we should be monitoring mental health, so not just our annual screening, but we should be monitoring, including screening for depression and anxiety before and no longer than 3 months after initiating a variant-specific therapy like ETI, BTD, and carefully assessing any changes in mental health. And there's also a really nice table here that will show you some protocols that you might use for dose adjustment. We'll talk about that in a moment. So what could we do if we're seeing some of these problems? Well, obviously, if people have improved mental health, there's nothing for us to do. Maybe they can even cut back their medication, right? Or they don't need as much therapy anymore. If they're having symptoms that are mild or tolerable, that might not need an intervention. We can also use psychosocial and psychopharmacologic interventions. So just like we would at any time, right? Support around adjustment and coping if people are having changes in body image related to weight gain, for example, with a modulator, or concerns related to their role changes, and even caregivers may have concerns related to their role changes, right? Who am I now that I'm not needed as much in the same way that my, the person I've been supporting with CF is healthier now. So we can provide that support. We can use behavioral strategies like sleep hygiene for insomnia, and we can use the usual treatments that we would use for any observed symptoms. So cognitive behavioral therapy has a large body of evidence for improvement of depression and anxiety, and so does medication, and the combination has been shown in quite a large number of randomized trials to be better than either one alone. And I'll point you to this paper at the bottom, the Baroud paper, where we did a retrospective look at adults in our center and how often we were seeing problems and how related they seemed or didn't seem to be to ETI, but also the management strategies that were shown to be effective in our population. Okay, so that's what we can do from a kind of psychiatry standpoint, psychology standpoint, but what do we do from a modulator standpoint? Well, we could adjust the modulator and see what happens, right? So we're thinking about relatedness. One of the ways we think about relatedness is what happened when you reduced the dose, what happened when you increased the dose, what happened when you stopped it, what happened when you restarted it. So we could discontinue, we could switch modulator, we could off-label reduce the dose, although again, we don't have a lot of PK data to guide us on exactly how to do that. This may help us kind of understand what's happening and whether this may be something that's related or unrelated. But of course, there's a major risk here, right? This could risk the loss of the benefit for CF. And for someone who's been really healthy, they may say, that's fine, I'm good with this. And for someone who's got advanced disease, this may be an unacceptable risk, right, to reduce the dose or discontinue. One strategy that some groups, particularly in the UK, have used and published on is to monitor sweat chloride and trying to keep that in the normal to borderline range as a way of seeing, where are we with dosing and is this where we want to be. So the Mental Health Advisory Committee has some resources on modulators and mental health that I wanted to make you aware of. They're available at my.cff.org in the resource library. We have tips for teams for a variety of age groups, and we also have a patient-facing handout as well on modulators and mental health. And so next steps for new research, there are a variety of studies that I won't have time to talk about that include mental health components as part of a larger study. I encourage you, as you're designing new studies, don't miss the opportunity to include mental health as a measure to add or an aim to add because it's really going to provide us with some super important data. And I wanted to mention the retrial data, which again was mentioned in the plenary as well. So for folks who participated in the VTD clinical trials, they were required to be stable on a full dose of ETI, right? So people who had modified or discontinued ETI due to neuropsychiatric symptoms or drug-related liver injury couldn't be included in these trials. And those folks, for them, they really want to know, if I switch to VTD, what's the likelihood this is going to happen to me again? Am I at a high risk for this? So retrial is a multi-site prospective observational study of people with CF ages 6 and above who again have neuropsychiatric adverse events or liver injury on ETI that required modification of dose or discontinuation. A wonderful team working on this project. We have a mental health arm, we have a liver arm, we have biobanking, and we have a neuro arm that's doing performance-based measures, which is optional. But importantly, the mental health arm and the liver arm are entirely remote, and we are recruiting nationally now. So if you have anyone that comes to mind who, again, is on a reduced dose or discontinued ETI because of liver reasons or mood, anxiety, sleep, cognitive side effects, brain fog, and they're planning to start a lift track, we don't dictate care. This is an observational study. But you can refer them to any of our study sites, and they can have closer monitoring and contribute to answering this question that's really important for folks with CF. And there is also CRISP funding available that will go into your center grant that you can apply for at the end of the year to compensate you for the work involved, which is not too much: medical records and having a mental health coordinator who's willing to take alerts for elevated depression. And I will end there.
Thank you so much. Another great talk.
Oh, I got this one. So wow, great talk. We'll take questions now.
Hey there, I'm Niall McCarty from Emory. I wonder if you can comment on the impact of CFTR deficiency and/or modulators on the choroid plexus, which is thought to be the kidney of the brain, epithelium, right? And the blood-brain barrier, which is packed with P-glycoprotein and other ABC transporters. If you got another 15 minutes or so.
Very curious about your thoughts on that. I don't know of any work in that area, but it sounds fascinating, right?
That was quick.
Leaky gut, do we have
14
kind of
minutes to go.
Leaky brain as well?
Yeah, and I wonder if anybody's, looked at the composition of the CSF in the same way that we've looked at the composition of the airway surface liquid. Because it's quite possibly modified. The CFTR is expressed in the choroid plexus for sure. And so I've never understood, why we don't have huge cognitive defects in our CF subjects.
Right. How is it that are they able to accommodate somehow during the course of development, right? So that the impairment isn't as profound as you would expect that it might be.
Right.
Right. And then what happens when you tip that balance? You've done all this accommodating and suddenly you have this corrector and
Yeah. Okay.
Yeah.
Thanks.
Thanks for a great talk. What are your thoughts on the impact of modulators on aging-related neurocognitive disorders? Like with long-term use, are we going to see emergent signals there, off-target effects?
Yeah, really fascinating. There was actually a study looking at CFTR in relation to dementia that had nothing to do with CF. So I think that is an open question. And it's something that also will be tricky, right? Again, just thinking about how do we tease out when something's a side effect, maybe with late onset versus actually this is just progression of dementia. And are people with CF at higher risk? This is certainly a priority area now for mental health, neurocognition. So thinking both about aging and also thinking about that early population. What's the impact of exposure to modulators, starting in infancy, and can we reassure parents about that? Again, for those who may be hesitant to start their kids on modulator, worrying about what those neurodevelopmental effects will be like.
Thank you for a nice talk. Paul Robinson, Brisbane. You mentioned in your talk that tezacaftor doesn't cross the blood-brain barrier. My question was, do we have any data to inform whether any of the newer compounds cross the blood-brain barrier, like vanzacaftor or deutivacaftor?
Yeah, that is a good question. I've been told that Vertex has just posted a whole trove of data, preprint, all their preclinical data. I have not had a chance to review it. I've just become aware of this. This is very recent, so I'll be very curious to kind of see what's in there.
Hi, I'm Ruth Sarah Bass. I'm a pediatric gastroenterologist at Nationwide Children's. I'm particularly interested in disorders of gut-brain interaction, and I was wondering if in any of the studies that you described, people had looked at GI symptoms in people with CF that had neuropsychiatric symptoms as well.
I think there may be a poster related to that here, but I didn't have a chance to go look at it. But I think, again, this is really an area that's very ripe for exploration.
And I have a follow-up question. So if we were to kind of look from the other side in our GI symptom analyses, are there any particular sort of high-yield either CNS surveys or biomarkers that we should be looking at when we look at things from a GI standpoint?
Well, there is a new measure called the GEMS CF modulator side effect measure, and so which has been actually had a robust preliminary validation and is having a national validation study now. So we actually do have a good measure of modulator-related side effects, so that may be interesting to include. But certainly clinically, we see that as well. Chris Vella's is at MGH, and we share those cases, right, where it's both the GI and the mental health that are flaring simultaneously often.
Thank you.
So we have at the brain level at least 8 ABC proteins. And some of them actually, ABCG2 actually was studied and responding very well to CFTR modulators. Also, at the brain level, at the blood vessels, we have ABCA1, which I'm sure would respond because if you're looking at ABC proteins, we have similarity between 35 to 57, 56% in the sequence. So potentially, I don't think so. It's only CFTR involved in all this adverse reaction. I think we're affecting all that other ABC proteins.
And what kind of models are you studying this in?
Not studying the models. I'm studying actually ABC proteins responding to CFTR modulators, and even they are not affected. They are normal. We would increase the expression. I'm just mentioning that we have at least 8, and ABCG2 was studied by Bill Gugino at Hopkins, and similarity was very high. And in fact, it's in the brain. I don't know if someone studied ABCA1, but in the blood vessels at the brain, because that could actually cross the barrier. And also ABCA1, it's neurons. So I guess it's worth looking
at. Yeah.
Right.
Well, if anyone has an interest in this area, we're putting together an animal models workshop through Prime for the first quarter of next year. So, come find me and let me know.
We're going to have our speakers come up, and we'll take that last question. And we'll also have our speakers come up to have about 10 minutes of open questions. It's a great multidisciplinary talk, and there's a lot of collaborative ideas. So we'll get everybody up here so they can answer together. Sir, would you like to go?
You mentioned about the UK group starting to use sweat chloride potentially as a way of adjusting the dose when faced with these sort of side effects. Do you have any anecdotal comments about how they're finding that approach?
Really what they did is to, they were looking at people with primarily neuropsychiatric side effects, reducing the dose and titrating to response, and then confirming with sweat chloride, okay, we're still in a normal level, we're in a borderline level, we feel kind of comfortable with this. And that's really what they showed. So, again, that suggests, could there be a PK issue here, differences in drug metabolism that we're still able to get that response despite, lowering the dose substantially. So again, it just, we obviously, clinically, you're trying to balance the, what people with CF kind of say is, I don't want to have to trade my mental health for my physical health, right? So where is that balance of my physical health is good enough and my mental health is good enough? And again, that sweat chloride may help us kind of feel a little more comfortable about where that is. And sometimes what people do as well is, if they're on a reduced dose and they're having an exacerbation, they'll go up and they'll say, I'll kind of deal with this mental health stuff. But ideally, what we'd like to do is treat the mental health concerns in other ways so that they can get the maximum benefit out of their modulator.
And so presumably in that situation, sweat chloride is just one of the things they're using to try and...
Exactly, to kind of try to tell where are we with this, right? And we don't have, unlike other drugs where we have good therapeutic drug monitoring and say kind of here's our window, we really don't have that yet. But again, there are folks working on trying to develop models that may help be able to guide that.
Okay, great. Do we have any other questions from the audience? Otherwise, we have some virtual questions that we can.
Hey, Kim, I have a question. It's actually for the previous speaker. Hi, my name is Danica from Case Western Reserve. We recently published this summer a study looking at increased tau in the hippocampus of CF mice that was associated with cognitive decline, impaired behavioral performance on these kinds of tests. So I'm wondering, given that we have shown hyperphosphorylated tau and decreased LTP in a rodent model, what's your prediction for whether or not that will translate to humans or people with CF as they age? Or have you seen that study?
I think I have, and it may have been the study I was thinking of. So again, come on up afterwards and let's chat about that. But that's, I think, what people are kind of worried about, right? And, are we going to have cohort effects based on people who've had chronic hypoxia and impaired nutrition early on and all of that, who may be at higher risk, or are there other things going on related to CFTR function that are going to put kind of everybody at risk? And then to what extent does early modulator administration mitigate that? Well, we've got tons of work to do, and this is a new frontier in CF.
We have a question from the virtual audience that I think is pertinent because it affects a lot of the different disciplines. Poor sleep and sleep apnea have been linked to increased incidence of diabetes and insulin resistance. There's now growing evidence of this in people with CF following modulator use. Any thoughts how this could be playing a role?
Is that the on button? There you go. Hear me. Great. I don't have much in terms of thoughts, in terms of pathophysiology of why that may be the case, but insulin resistance, certainly, I mean, there we have endocrine, that is probably the hottest topic right now. Again, the cardiometabolic landscape and insulin resistance and the crossover between more of a type 2 phenotype and CFRD, and we're using a lot of GLP-1s as a result, and there have been a couple of specific talks on that. So I would think that the most of it would be kind of a crosstalk in that phenomenon with the type 1 world the type 2 world and CFRD, but don't have a lot else. That is why.
I have a question. I think this is mostly for Nicole and Kevin, but why don't things get better with ETIs in terms of CFRD, in terms of GI symptoms? So, for example, in intestinal stem cells, you see clonal memory. So if you get a stem cell from an inflamed tissue, there's epigenetic marks that persist even after the inflammation is gone. So could that play a role? Like, again, once you just don't have a functional CFTR for long enough, then you're kind of just stuck? Or are there other things that you think could be going on?
Yeah. I think the answer is we really don't know, and were surprised that we weren't seeing more of an effect. I think, so there's obviously dysfunctional CFTR, but we know people with the, same mutations can have very different GI manifestations of CF. So what to focus on. And again, I think there's a growing interest and need to focus on sort of disorders of brain-gut interaction. And I think that may be a large part of it. And I think, even the signs of like intestinal inflammation improving with CFTR modulators none of the patients from a GI perspective, even those with abnormal calprotectin, they weren't really that high from a gastroenterologist perspective. 200s, 300s aren't striking for GI. So I think we need sort of better assessment tools and better things to focus on and target than just, CFTR itself. And I think there should be more interest in the brain, gut, and neuroenteric system.
I think it definitely comes back to our need for that data in youth. Because your question from my standpoint is the degree of beta cell dysfunction and exhaustion, even if the cells are still there, so significant that it can't be overcome just by all of a sudden introducing ETI or the neuromodulators. And I think that answer is probably really only going to be, or that question's only going to be answered with time when we see that data from younger individuals.
I think the other aspect too is some of the, again, from the heterogeneous response aspect, there's PK factors, there's deposition, there's other things. I think our different cell types and cell tissues are not always seeing the same level of drug, and things are not optimized to each individual. So there's probably a role that plays across systems for that.
In these varied responses, anybody thought about revisiting the role of genetic modifiers?
Yes, but I think there are people that are certainly working in that space, and certainly it impacts your immune system as a whole.
So another comment here. On a big picture, actually, we had to publish a manuscript, and reviewer would not let us go until we don't find what is affecting in the liver. Why do we have liver toxicity from the CFTR modulators? So I use different mice. I use normal mice. I use polycystin 1, actually, polycystin 2 mice modified because that is controlling the calcium. And what we found that actually CFTR modulators really changing not only the CFTR, and we recently found that the CFTR, it's really stay at the base, like backbone to control the calcium. Once we use the CFTR modulator, we're changing the calcium level. And that is what we found actually in the liver. In the liver, we found that the mice which had defective polycystins were actually controls as a channel, calcium channel, that would not have any liver toxicity, actually would improve the liver function. But normal mice, actually, normal mice which has the calcium normal, because all the other genes control the calcium, they're normal, that would have liver toxicity. And we're looking at the CFTR modulators, really, we're seeing in the kidney, the sodium falls off the membranes from the collecting and proximal tubules. This would explain why they would have high blood pressure. And a normal mice, because we would increase that. So we have to keep in mind the CFTR modulators, they're not really specific for the CFTR only, but having off-target effect on the other proteins, not only ABC, that would actually give us all this liver toxicity, high blood pressure, eye problems, and all sorts of things. So we have to expand, I think we have to expand to look into different pathways.
Yeah, super interesting. Thank you.
Question for Ben. In your talk, you seem to suggest that the duration of response with ETI might vary across macrophages and neutrophils. So the neutrophils seem to have a bit more of a sustained response. If that's correct, I was just wondering why you thought that might be happening.
I think the data you're seeing often with neutrophils are such short-lived cells, so that washout period is not necessarily an impact there. So again, they're doing day of studies and freshly isolated, so they're much shorter lived cells than your longer lasting populations. So, but I think with any cell type, it's going to be the same way that our people with CF experience it. They need the constant exposure. So it's a 24-hour kind of cellular effect.
Yeah.
Are there any other questions? Well, I think this session really elucidates that this is a multi-system disease, but this is also now a systemic drug, and more collaboration between the disciplines, crosstalk between clinicians and the scientists really could advance the research. So thank you so much for this group coming. I really appreciate it.
Great.